Hello, ladies and gentlemen. Hello, everyone. From now on, our new broadcasting program series, Consultant Medical Oncology North Cyprus TV channel Onco Duo. This program especially public health education basis series. Our books, one of them, source, the MD Anderson Manual of Medical Oncology. First program, acute lymphoblastic leukemia, epidemiology and etiology. Acute lymphoblastic leukemia is characterized by the expansion and proliferation of lymphoid cells in the bone marrow, blood, and other organs. Acute lymphoblastic leukemia occurs with an incidence of 1 to 1.5 per 100,000 population. Although with a bimodal distribution, an early peak at around the age of 4 to 5 years, where the incidence may be as high as 4 to 5 per 100,000 population, followed by a second gradual increase at around age 50 years, where it reaches up to 2 per 100,000 population. Acute lymphoblastic leukemia represent the most common childhood pediatric leukemia, representing about 80% of acute leukemias, while it comprises only 20% of adult leukemias. The median age of acute lymphoblastic leukemia patients in most registry studies is between 25 and 35 years. Acute lymphoblastic leukemia is the most common type of cancer in children aged 0 to 14 years, and is relatively uncommon in late childhood, adolescence, and young adulthood. The etiology of acute lymphoblastic leukemia remains unknown. Chromosomal translocations occurring in utero during fetal hematopoiesis have been suggested as the primary cause for pediatric acute lymphoblastic leukemia, whereas postnatal genetic events are suggested as secondary contributors. A higher incidence of acute lymphoblastic leukemia is noted among mono and dizygotic twins of patients with acute lymphoblastic leukemia, reflecting possible genetic predisposition. Patients with trisomy 21, Klinefelter syndrome and inherited disease with excessive chromosomal fragility such as Fanconi anemia, Bloom syndrome, and ataxia telangiectasia have a higher risk of developing acute lymphoblastic leukemia. Implications have also been made toward infectious etiologies, associations between human T-cell lymphotropic virus type 1 and adult T-cell leukemia lymphoma, as well as HIV and lymphoproliferative disorders have been established. In addition, associations with varicella and influenza viruses have also been suggested. Clinical presentation and laboratory abnormalities. Clinical presentation of acute lymphoblastic leukemia is usually non-specific. Symptoms typically include fatigue, lack of energy, easy breathing or obvious bleeding, dizziness, and infections. B symptoms such as fever, night sweats, general, or weight loss can occur. Extremity and joint pain may be the only presenting symptoms in children, whereas symptoms related to hyperleukemia, hyperleukocytosis can occur in acute myeloid leukemia. They are rare in acute lymphoblastic leukemia, even in the presence of high white cell counts. Central nervous system involvement, cranial neuropathies, meningeal infiltration at the presentation common in mature B acute lymphoblastic leukemia. Burkitt leukemia occurs in 5 to 8% of patients. Abdominal masses and significant spontaneous tumor lysis syndrome. You know, tumor lysis generally cause some very important molecules pouring cellular outside environment and make paraneoplastic syndrome and others. Tumor lysis syndrome are more likely with mature B acute lymphoblastic leukemia, lymphadenopathy, and hepatosplenomegaly. Rarely symptomatic are noted in 20% of patients. with a higher incidence in T cell, acute lymphoblastic leukemia, and mature B cell, acute lymphoblastic leukemia, the combination of hypercalcemia and lytic bone lesions is suggestive of adult T cell leukemia lymphoma. Shin numbness, mental nerve involvement, when elicited in the history of exam in suggestive or mature B cell acute lymphoblastic leukemia, Burkitt. Diagnosis. The diagnosis of acute lymphoblastic leukemia relies on assessment of morphology, flow cytometry, immunophenotyping, and identification of cytogenetic molecular abnormalities. Chromosomal aberration abnormality, polyploidy or other different characters. Defining acute lymphoblastic leukemia subtypes with different response to therapy and prognosis that are only partially discriminated by current diagnostic tools may be further determined by genomic profiling. Cytogenetic molecular abnormalities. Recurrent cytogenetic molecular abnormalities are common in adult acute lymphoblastic leukemia. In addition to their prognostic significance, they provide insight into the molecular events underlying the leukemic phenotype, differences in the frequency with which good and poor prognosis karyotypes occur in childhood versus adult acute lymphoblastic leukemia partly explain differences in outcome among children and adults. Oligonucleotide or cDNA microarray technology are being investigated to identify previously unrecognized molecular acute lymphoblastic subtypes. And continue this paragraph. Therapy generally non-existence. Our programs from time to time may be a bit expression something. Stem cell transplant in the therapy in both risk group of patient, allogenic transplant reduce the rate of relapse compared with the chemotherapy or autologous stem cell transplantation for patients without a suitable donor. Chemotherapy is favored rather than autologous stem cell transplant. And this program last summary Historically, remission rates for acute lymphoblastic leukemia in adults have been comparable to that in children. However, long-term survival remains a challenge. Progress in adults has been marked by utilization of intensive regimens, proven beneficial in pediatric patients, as well as the inclusion of new targeted therapy. Future therapy with acute lymphoblastic leukemia will incorporate novel agents to already active regimens, inclusion of asparaginase products into regimens like hyper-CVAD and BFM may improve long-term survival. Determination of high-risk patients through molecular testing will allow for personalized therapy, whereas the detection of early MRD will help select patients requiring further therapy. In Ph positive acute lymphoblastic leukemia, advanced generation TKAs may improve response rates and allow for more patients to proceed to stem cell transplantation development in supportive care, such as prophylactic, preventive medications, growth factors, and granulocyte transfusion enable more patients to tolerate intensive regimens. Although significant discoveries have been observed in the treatment of patients with acute lymphoblastic leukemia, long-term survival is adult in still inferior to that in children. Through continuous investigation, comparable outcomes may soon be achieved in adults. That's all this program and other program. Adult acute myeloid leukemia. Adult acute myeloid leukemia. Acute myelogenous leukemia is a group of several different diseases, the treatment and outcome of which are dependent on several factors including leukemia karyotype, patient age, and comorbid conditions. Despite advances in understanding the molecular biology of acute myelogenous leukemia, its treatment remains challenging. The standard regimens using some chemotherapy for induction followed by some form of post-remission therapy produce response rates of 60% and 5-year survival rates of 25%. New therapies are emerging based on the definition of specific cytogenetic molecular abnormalities. Such targeted therapies offer the promise of better anti-leukemic activity in adult acute myelogenous leukemia. Introduction. Acute Acute leukemia are clonal malignant hematopoietic disorders resulting from genetic alterations, genetic abnormalities in normal hematopoietic stem cells. These alterations induce differentiation, arrest, and or excessive proliferation of abnormal leukemic cells or blasts. Acute myelogenous leukemia, acute non-lymphocytic leukemia is heterogeneous. Over the past several decades, improvements in chemotherapeutic regimens and supportive care have resulted in significant but modest progress in treating acute myelogenous leukemia. Better understanding of the biology, acute myelogenous leukemia has resulted in the identification of new therapeutic targets. Despite current optimism, most patients with acute myelogenous leukemia still die of their disease. With better molecular definition and elucidation of the physiopathology of acute myelogenous leukemia subtypes and development of new and targeted therapies and a better outcome of acute myelogenous leukemia may be achievable in the future. Epidemiology, etiology, and risk factors. About 13,000 individuals are diagnosed annually in the United States with acute myelogenous leukemia. The incidence of acute myelogenous leukemia is 2.7 per 100,000. The median age at presentation is about 65 years. The incidence of acute myelogenous leukemia along with its precursor myelodysplasia appears to be rising, particularly in the population over age 60. In adults, acute myelogenous leukemia is by far the most common type of acute leukemia. The incidence of acute myelogenous leukemia is slightly higher in males and in populations of European descent. Acute promyelocytic leukemia, APL, acute promyelocytic leukemia, a distinct subtype of acute myelogenous leukemia, is more common among populations of Latino or Hispanic background. An increased incidence of acute myelogenous leukemia is seen in patients with disorder associated with excessive chromatin fragility such as Bloom syndrome, Fanconi anemia, Kostman syndrome, and with Wiskott-Aldrich syndrome or ataxia telangiectasia. Other syndromes such as Down trisomy or chromosome 21, chromosomal aberration, Klinefelter, XXXY and variants, and Patau, trisomy of chromosome 13 have also been associated with a higher incidence of acute myelogenous leukemia. Survivors of the atomic bomb in Japan had an increased incidence of myeloid leukemias that peaked 5 to 7 years following exposure. Therapeutic radiation increases acute myelogenous leukemia risk, particularly if given with alkylating agents. There are two main types of therapy-related acute myelogenous leukemia: the classic alkylating agent type, etc., cyclophosphamide, melphalan, nitrogen mustard, has a latency period of 4 to 8 years and is often associated with abnormalities of chromosomes 5 and or 7, exposure to agents that inhibit the DNA repair enzyme topoisomerase 2, etc., etoposide, taniposide is associated with secondary acute myelogenous leukemia with a shorter latency period, usually 1 to 3 years, with chromosome 11q23 at the location of MLN gene and with M4 or M5 morphology. Drugs such as chloramphenicol, phenylbutazone, chloroquine, and medroxyzoroalen can induce marrow damage that may later evolve into acute myelogenous leukemia. Benzene smoking, dyes, herbicides. Benzene smoking, dyes, herbicides, and pesticides have been implicated as potential risk factors for development of acute myelogenous leukemia. Acute myelogenous leukemia may also be secondary to progression of myelodysplastic process or of chronic bone marrow stem cell disorder, such as polycythemia vera, chronic myelogenous leukemia, essential thrombocythemia, and myelofibrosis. Clinical presentation. Fatigue, bruising or bleeding, fever, and infection, reflecting a state of bone marrow failure, are common in acute myelogenous leukemia. Only 10% of patients present with white blood cell counts greater than 100 times 10^9 per liter. These patients are the higher risk of tumor lysis syndrome, central nervous system involvement, and leukocytosis. Leukostasis may manifest as dyspnea, chest pain, headache, altered mental status, cranial nerve palsies, or priapism. Leukostasis and tumor lysis syndrome are oncologic emergencies and require prompt recognition and management. Physical findings other than bleeding and infection may include organomegaly, lymphadenopathy, sternal tenderness, retinal hemorrhages, infiltration of gingivae, skin, soft tissue, or meninges, more common with monocytic variants M4 or M5. Disseminated intravascular coagulopathy with bleeding diathesis is a common presentation in APL, acute PL. Yes. Diagnosis and classification. Treatment, acute myelogenous leukemia. Standard therapy, conventional treatment for acute myelogenous leukemia divided into remission, induction, and post-remission therapy. Prognostic factors with standard therapy. Prognostic factors can be divided into those primarily associated with early death and those primarily associated with resistance to chemotherapy. Normal karyotype genetically is associated with responsiveness to induction therapy and better survival. Normal karyotype is associated with responsiveness to induction therapy and better survival. Supportive care. Adequate and close supportive care is extremely important in the care of acute leukemia. From existing randomized studies, GCSF appears to be better and safer than GM-CSF. Tumor lysis characterized by hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, acidosis, and renal failure. Prevention of tumor lysis syndrome requires administration of intravenous fluid and allopurinol or rasburicase. Yes. Conclusion. Following a period of paucity in discoveries, new strategies are finally evolving that may help patients with acute myelogenous leukemia. The biology of the disease is now better understood. Patients with CBF, acute myelogenous leukemia, have high cure rate with histone deacetylase. Patients with APL have been benefited from newer treatment with all trans-retinoic acid and arsenical derivatives. Better definition of the complex process initiating and sustaining the leukemic process will lead to better definition of targets for therapeutic intervention that may translate into improved cure rates. Specific attention must be given to prognostic factors that identify subset of acute myelogenous leukemia in which a specific tailored therapy will be helpful. That's all. Our second program. That's all. We will be continue other program. Thank you very much. Thank you so much. Your patience. See you later.